Well, hello, and welcome to Radiologic Science and Patient Care. This is in your Radiologic and Imaging Sciences and Patient Care book. This is the 7th edition, and this is for the Intro to Radiologic Technology class. First, before we start looking at this PowerPoint and listening to the lecture, let me tell you that the best way to go about this would be to have access to that PowerPoint. Ideally, it would be printed out so that you could take notes on the slides, and also to go along with the book as we go. I'll try and reference page numbers, tell you where we're at. I will tell you that this will start on page 2 of the book. And the easiest way to go about looking at this, the first thing I would tell you would be to look at the objectives of what you're supposed to learn out of this chapter, and also to look at the key terms. Now, I don't expect you to regurgitate the key terms word for word, but just looking at those terms, for example, in chapter 1, there's bone densitometry, cardiovascular interventional technology, computed tomography, diagnostic medical sonography. I mean, there's 6 or 8 of them on page 2, and then there's another probably 8 on page 3. And it's just a good idea to read through those for each of the chapters, just so that you get an idea of what kind of information they're going to be throwing at you. So the best way, again, just to have your book available to you as we go through. Print out the PowerPoint lecture if you can, and take notes. And anything that you don't understand on there, it would be ideal to write down so that you can ask during the lecture. Okay, so we'll start on page 2 and page 3 with this, and this is an introduction to chapter 1. If we look at the objectives, they reference that we'll explain the use of radiation in medicine, provide an overview of the history of medicine. Now, that is going to be minimal, if non-existent. Not that it's not important, but we tend to focus more on what we do in our specific field, but it is worth reading, but I will not quiz or test you on that part of the chapter. We're going to describe the discovery of X-rays, probably more in depth than what the book goes into. Look at terms related to radiologic technology, explain the different opportunities we have within our profession, which are endless, and identify the different specialties within our department. We'll also describe the responsibilities of the members of the radiology team, and we will recognize that it is a team effort. There are multiple people that make up the radiologic team. Explain the career ladder opportunities in the department, and discuss the roles of other members of the healthcare team, because basically in the hospital setting or outpatient setting, there are many members of the healthcare team that provide services to the patients. When we look at medical radiation sciences, this is where we actually use energy to create images of the human body. And there's different energy forms that can be used depending on what you're actually applying or what you're actually looking at. And some of the energies actually create ionization in the patient. Ionization, by definition, is when the radiation has the ability to ionize atoms in matter. And typically when we speak of matter, matter is anything that has mass, occupies space, and has shape. Usually when we talk about matter, we're talking about the patient. But ionization is where a neutral atom either gains or loses an electron, and then it acquires a net charge. Now, typically when we're talking about radiation, we're talking about it'll lose an electron. Like when the radiation comes in and interacts with the atoms in the body, it'll cause an electron to leave an atom, and that will cause ionization. That's actually what makes what we do dangerous. I don't ever want to diminish the fact that what we do is not dangerous, but if done appropriately and if the appropriate precautions are taken, then what we can be relatively safe, but I don't ever want you to misunderstand that radiation is safe. It is not. They're called X-rays for a reason. When Rankine discovered them, he named them X-rays because X is the variable for the unknown. And though we do know quite a bit about X-rays, I would still argue that we don't know everything. And the capability of radiation and the fact that it ionizes is still dangerous. That's why we try and minimize the amount of radiation we expose a patient to. We actually follow what's called the ALARA principle, ALARA, and that stands for as low as reasonably achievable. And when we become technologists, we agree to practice using the ALARA principles, meaning that we try and minimize the amount of radiation that a patient is exposed to, not only a patient, but other co-workers. We always try and minimize the amount of radiation. So that is very important to understand. I don't ever want you to think that what we do is taken lightly. You'll find that as techs have been in the field longer and longer, they tend to just kind of be like, oh, it's no big deal. But I've been doing this 30 years, and it is absolutely still a big deal. You have to keep in mind that what you do has the potential to harm patients, okay? So some energies actually do ionizations in the human tissue. And the energies that are used are kept at safe levels for diagnostic and therapeutic purposes. That's what I mean when we talk about the ALARA principle. We do try and keep them at a safe level. I would argue that no level is absolutely safe because different people respond or react to radiation differently, meaning you don't know their radiation history. You don't know how much radiation they've been exposed to. And it's not only medical radiation that we're speaking of. It is possible there is naturally occurring radiation. I mean, when you think about the sun, people can get a lot more damage from going out in the sun without sunblock than what we can typically give them in the radiology department. But you don't know if they've had previous radiation treatment. You don't know how much they've been exposed to. You don't know what kind of work they're in. So we always try and be mindful that what we do can be considered dangerous, and we try and minimize how much we expose them to. When we look at the different energy forms for imaging, they reference that there is electromagnetic energy, which is actually what we use is electromagnetic energy. There's different forms of energy. And when you look on page 3, it says that energy is the capacity to do work. And the different forms of energy include the mechanical energy, electrical, heat, nuclear, and electromagnetic. And there's also chemical energy, which they left. But that is included. So there's mechanical, electrical, heat, nuclear, chemical, and electromagnetic. Now, the electromagnetic energy is what X-rays are made of, is electromagnetic energy, and those do have the ability to ionize atoms. We have radio waves that are used in MRI. Those do not ionize. Sound waves, which absolutely are not ionizing, but they use those in diagnostic medical sonography. They use the sound waves to bounce off matter and to give an image. With electrical, we use electrocardiography or EKGs or ECGs when they look at the electrical activity of the heart. You can also use that with electroencephalography, where we image the electrical activity of the brain. And again, this is all found on page 3. We have heat or thermal energy, which is used, that can also produce images. Those are called thermograms. And they're useful in demonstrating conditions like changes in the body's circulation. They can do that with ultrasound. They can turn on like the color flow Doppler and look at circulation. And a lot of times chiropractors can also use thermograms to show where there's increased blood flow to areas of the body that are injured. We have magnets are used with the radio waves. Magnets and radio waves are used in magnetic resonance imaging. They use those and they align the cells in the body. It kind of states. Now, MRI is also not ionizing because it uses the radio waves and the magnet. There is no ionization that takes place with the patient, but it's an alignment of the poles of the cells, and they actually can get images. Typically, MRI is used more for muscle, tendons, ligaments, things like that. We can see bone on MRI, but typically it's done more for soft tissue injury versus bone. Excuse me. Okay, and then we also have nuclear energy. And nuclear energy is emitted by the nucleus of a radioactive atom. Now, I recognize in your book it says that nuclear energy is emitted by the nucleus of an atom, but it's not just any atom. Otherwise, that would mean everything gave off nuclear energy. It's the energy released from a radioactive atom. And this is also used in imaging. This is done in nuclear medicine, and typically in nuclear medicine we'll look at the fact that they look at more physiologic action versus anatomy. Okay, so all of these different energy forms are used for imaging. X-rays are absolutely ionizing. Diagnostic medical sonography is not. Radio waves and magnets and MRI are not. Electroencephalography and electrocardiography using electrical energy are not ionizing. Pretty much everything on here is not ionizing other than x-rays, and nuclear medicine is ionizing because they use radiopharmaceuticals. What happens with x-rays, what we produce out of the machine is ionizing, and it passes through the patient. In nuclear medicine, you have radiopharmaceuticals that emit the gamma radiation from the nucleus, and those are either ingested, inhaled, or ingested, or injected, into the patient. So the patient either breathes it in, swallows it, or it's injected into them, so that in nuclear medicine, the patient is actually radioactive versus the equipment. The equipment in nuclear medicine simply detects the gamma radiation that is being given off by those radiopharmaceuticals that are in the patient. When we look on page 4, this is the electromagnetic spectrum. This spectrum goes, how you would look at this is looking from left to right. This is the low end of the energy spectrum. Okay, you can see on the low end, energy-wise, you're in the 10 to the negative 12th, and then as we go to the high side, we're over 10 to the 9th power. Okay, as far as wavelength and frequency and energy, we'll talk about that more next month when we get into the basic physics class, radiation physics. But when we look at this, we look from left to right. So on the low end of the spectrum, we have heat. Okay, very low end, low energy. Nothing is really ionizing until we get up to X and gamma rays. Those are ionizing. Remember, we said X-rays are what we do in diagnostic radiology. There's also therapeutic X-rays that they can use in radiation therapy. And gamma rays are used in nuclear medicine. These absolutely are ionizing. All of these, heat, radio, visible light, infrared light, ultraviolet light, are not ionizing radiations. But to look at the low end of the spectrum, the very lowest end would be heat, followed by radio waves, which we use those in MRI. And then we have infrared light, visible light, and this is the visible light spectrum. We probably learned in school, Roy G. Biv, or where the visible light spectrum goes red, orange, yellow, green, blue. When I was in school, there was indigo and then violet, but now it's just red, orange, yellow, green, blue, violet. So that's the visible light spectrum that's important to us, because this visible light is how we actually view the x-rays, whether they're on a view box where we hang up film and look at them, or we look at the light that's emitted from the monitor on digital imaging. So there's some important parts to us in radiology on this spectrum. That would be the radio wave portion, because we use those along with a very strong magnet in MRI. The visible light spectrum is important because that's how we actually visualize the information that we've captured on the image receptor where we've taken the picture of the patient. And the x-ray portion is important to us as well, specifically the diagnostic x-ray. That's where we tend to work, is in diagnostic x-ray, and we'll talk about in a minute the difference between diagnostic versus therapeutic. So this would be in radiology, in the imaging. This is more in radiation therapy, where they use therapeutic levels, higher levels of x-rays to actually treat things like cancer, surface cancers, things like that, skin cancers. Whereas in diagnostic radiology, we're doing it to diagnose, to see what's going on with the patient. And when we're talking about therapeutic x-ray, that's when you know what's wrong with the patient. You're using those x-rays to therapeutically treat or to improve the function or the condition of the patient. Does that make sense? Like diagnostic, when you're doing something diagnostic, you're trying to decide or to come up with information to diagnose the patient, to find out what's wrong with them. Once you know what's wrong with them, then they provide, not just in radiology, but I'm saying once they know what's wrong with the patient, they will do therapeutic measures to figure out how to improve the function. Like if we think about respiratory therapy, a respiratory therapist's job is to evaluate a patient and see why they're short of breath, why they're having difficulty breathing, why they get so winded when they walk to the mailbox and back. So once they diagnose the patient, then they do therapeutic things to improve the function of their breathing. Like maybe they give them a breathing treatment. Maybe they put them on an exercise regimen to improve their lung capacity, to build that up and make it increase their lung capacity so that they're able to breathe better. So that's pretty much the difference. When you're doing diagnostic medicine, you're diagnosing the patient, and then therapeutic medicine is designed to improve the function or the condition of the patient. Now, one more thing I wanted to point out about this spectrum, something that's unique on this spectrum, is that everything on here travels at the speed of light. Okay, and the speed of light, I'm going to tell you this, so you might want to write it down. The speed of light is 3 times 10 to the 8th meters per second. I will attempt to write it, but let me tell you that my writing on here is not very good, but it is 3 times 10 to the 8th meters per second. All right, and if we calculate that out, it actually calculates to 186,400 miles per second. Okay, 186,400 miles per second. So that's pretty darn fast. That is the speed of light, and that is the rate at which all of these energies travel. So heat, radio waves, visible light, infrared light, ultraviolet light, gamma rays, x-rays, and cosmic rays. The unique thing they all have in common is that they all travel at the speed of light. That's what's unique about electromagnetic energies. And everything on this spectrum is considered an electromagnetic energy. All right, now the difference between diagnostic and therapeutic levels, the diagnostic range of x-rays is 30 to 150 kVp, and we'll talk about that more later on, but that stands for kilo voltage peak. Kilo, K-I-L-O, voltage peak. So kilo is 10 to the third, or 1,000. So it's 30,000 to 150,000 volts is what we're talking about. So that's the range that we use. When we take diagnostic images, our control panel is set somewhere between 30 and up to 150 kilovolts. To be honest with you, I've never really used anything lower than about 46 kVp, and I've never exceeded 125 kVp. And I know that won't mean much now, but it will in the future, but that's the range of diagnostic radiology. When I talked about the therapeutic level, the minimal therapeutic range, you would have to be up at about 500 kVp. Now that's when they would treat like some surface skin cancers, things that are very shallow. They can actually treat skin cancers is probably one of the most common that they can treat with radiation in radiation therapy, but minimally they're at about 500 kVp up to about 30 mega electron volts, which is 30 and then capital M EV. M is 10 to the 6th. So extremely high energy to treat that kind of cancer is typically what we're talking about. So diagnostic range, this is where we typically operate as a radiologic technologist, and then a minimal therapeutic range, which a radiation therapist would operate, would be at the lowest would be 500 kVp all the way up to 30 mega electron volts. Next in the book comes the history of medicine, and I told you that we weren't going to focus on that. Not that it's not important, but it's just not something that we're going to look at this time. So we are going to flip all the way over to page 6, and this is talking about radiography. Actually, what they do is they kind of, they're going to talk about all the different things that we can become, the things that we can actually look at as far as different fields, and then we'll talk about the history of radiologic technology. So this is actually looking at the different opportunities that we have. So it's still on page 6. It is on the right-hand column, and these are opportunities in radiologic technology. So the first thing is that you are in school, you are in class to become a radiologic technologist. Okay, so in radiography, this is something that we absolutely could foresee yourselves doing in the future. This is the technologist right here. This is the little pediatric patient. There's an image receptor behind this patient, and the tech is probably telling the child what is going to be done. This is the X-ray tube over here that we use. This is the X-ray table. And then, like I said, this is the image receptor that'll capture the image for the patient. So in radiography, we use electromagnetic energy in the form of X-rays to create medical images. And those images are of the patient, typically some anatomical part of the patient. This looks like it would likely be a chest X-ray on this child. The energy creates ionizations, which create the medical image as well as harming living tissue. Now, the fact that the body ionizes the radiation, that's what actually allows us to capture the image. Some radiation will pass through the patient and strike the image receptor. That gives us our dark areas or our black or our really dark gray shades on our image. And some of that radiation will actually stay in the patient. It will be absorbed in the patient, and that will give us the white areas on our radiograph. So X-rays are typically made up of a difference between dark and light shades, and the way those dark and light shades are achieved is how the radiation passes through the patient. But recognize as it passes through, it does have the ability to ionize, which remember that's the gain or the loss of an electron, which actually is harmful to the patient. Okay, we cannot say that it's not harmful. We can say that we do everything we can to keep it relatively safe, but it is still not 100% safe. You can see that the technologist is wearing a lead apron. This is called a shield. And so does the patient have this shield on her lap. Okay, so this shield on her lap is protecting her gonads or her ovaries. Ideally, especially if we're imaging the chest, then we would shield the patient. And the technologist is probably going to stay in the room and help hold the patient still or in the correct position. So the technologist, whether it's a male or female, would have to also wear some kind of lead apron to protect their vital organs against the radiation. You recognize that the patient's only in here probably once, twice, however many times, but the technologist works in this field. So even more important that they are shielded when they are in the room. And ideally, if they don't have to be in the room, they would not be in the room so that they minimize their radiation exposure. It says that competent radiography requires the safe use of electromagnetic energy. So if you're a competent radiographer, if you are a prudent practitioner, then you operate safely all the time, always acting in the best interest of your patient, co-workers, along with yourself. You want to keep the radiation dose, remember we said it's that ALARA principle, as low as reasonably achievable. Now, this is what all of you will become when you graduate the program and pass the registry. You will become a radiologic technologist. And that is a term that's applied to people that are qualified to use X-rays or radioactive substances in order to produce images of the internal parts of the patient's body. And then those images are interpreted by a radiologist. And the radiologist is actually a medical doctor that specializes in reading the images that the radiologic technologist has taken. All right. Next, we'll talk about diagnostic medical sonography. Now, this used to be something that we could cross-train into, but I will tell you that currently it is really not. It is an entire separate program. It is completely different because we use ionizing radiation, we use electromagnetic energy, and diagnostic medical sonography actually uses sound waves. So sound waves are not on the electromagnetic spectrum. Sound waves literally need sound, and it bounces off the matter and produces an image using sound waves. So much safer than radiation because there is no ionization that takes place. So notice here it says that it uses high frequency sound energy to create the medical images. It is non-ionizing, and it has a wide variety of medical applications. Now, typically, we always think of sonography as imaging babies. That is the most common form, but it absolutely is not the only thing that sonographers do. There is imaging of all kinds of body parts, typically organs. You can image the gallbladder, you can image blood vessels, you can image organs, liver, pancreas, you can image babies, obviously. You can image the prostate. You can image in the vagina. I mean, there's all kinds of imaging that can take place, very wide field, so it is not limited to just fetal imaging, but a lot of people think that that is the only thing that they do. But when they graduate from that program, they are known as diagnostic medical sonographers. And again, they use sound waves to image the body. Then we have magnetic resonance imaging, or MRI. MRI uses the energy of a high-strength magnet and radio waves, and that creates images of the human body. It also is non-ionizing. Okay, you can see in here that the patient is in this kind of open scanner. One of the technologists is out there with a patient. I mean, not ideal, but they might just be positioning at this point because that magnet is very, very strong, much stronger than your refrigerator magnet. When we used to walk by the MRI suite, anything that you had that was metal would pull towards that. Now they usually have a door that is kept closed so that people that are passing by, that does not affect. But I can also tell you that there's different zones now with MRI where if you're not qualified to a certain level, you're not even allowed back near the magnet. Typically, the technologists are allowed back there. Have to have a certain level clearance. Students are allowed back there when you're in a facility that has MRI, but patients are not allowed to wander back there. Anyone that is not MRI personnel and not at a certain level of qualification would not be allowed back there. But you can see on this monitor, they're imaging. Right here you can see, I believe, kidneys. You can see the blood coming down and blood vessels over here. So again, done more for soft tissue versus bone anatomy. Then we have CT scanning or computed tomography. All right, computed tomography is ionizing, and it uses X-ray energy and software to create cross-sectional images of the body. Pretty much CT and MRI use what's called sectional imaging, where it almost like if you imagine a loaf of bread, that's the easiest way to think of it. If you had a loaf of bread sitting in front of you, there would be all slices that make up that loaf of bread. So you could look at the loaf of bread as a whole, or you could take out individual slices and image it or look at it that way. With CT and MRI, it does the same thing to the body. It takes sectional images of the body. One example would be like a loaf of bread, and you could look at it as a whole, or you could take out a specific slice and look at the anatomy in that specific slice. Now, those are not the only way that they image, which if you think about a loaf of bread, it would be from top to bottom. They can also image from side to side. Those are called sagittal cuts. The images that are from top to bottom are considered coronal cuts. There's all different kinds of image that they can do, but both CT and MRI use sectional imaging. But again, CT is ionizing using radiation. MRI is not. MRI uses a magnet and radio waves. And what it does is, you can see here, it says it gets hundreds of views of the patient's anatomy as the X-ray tube and the CT detector rotate around the patient. So the patient is on this table. It slides into what's called a gantry, and they slide the patient in as to whatever part they're imaging. Maybe they're imaging the foot or the leg. They could image the thorax or the head. Whatever they image, they slide the table in as far as they need to, and then the machine takes those sectional images, and then it's recreated on the computer screen for the technologist. Next, we have nuclear medicine. Okay, and we said nuclear medicine, you absolutely have to go. I should point that out. Let me go back for a minute. So when you graduate, you become a radiologic technologist. That is what your baseline education gives you, is this degree. There is no more schooling, because that's what you've just spent your time in the program. If you were to go on to diagnostic medical sonography, you would have to enter a completely separate program and go through all of that training. There is nothing where you can cross over and train to become a diagnostic medical sonographer. To become an MRI tech, you can cross-train, and there are some schools that offer additional schooling. They're anywhere from, a few weekends up to 3 months and 6 months schooling. The main reason people go to school when they're in MRI is because you need that schooling in order to pass the registry. To practice in any of these other modalities, you typically need to pass what is called a registry exam. So when you graduate and you take that test at the end of the program that is given nationally and you pass it, that means you passed your registry, and that's how you earn the initials behind your name. So when you graduate this program and you pass that registry, it will be your name followed by the initials RT, which stands for Radiologic Technologist. And then in parentheses, you get a specific initial behind your name. So the first initial you would get would be an R for radiography. When you become a CT tech and pass that registry, you get the initials CT behind your name. If you were to pass the registry in magnetic resonance imaging, you would get MR behind your name. And every initial you get by passing that registry, whether it requires a digital schooling or not, you add those initials behind your name. So you could have alphabet soup behind your name, which typically involves more money being made, but it also, you have to recognize that at some point you can become overqualified, where you have too much knowledge and a facility is not able to employ you because the amount of money they would have to pay you exceeds what they're allowed. So most people go right from radiology into CT, and then a lot of people also like MRI as well. Those are the two biggest because it does not require additional education from a university standpoint. It would require additional education as far as cross-training and then possibly going through one of those shortened school sessions to learn how to take the registry, how to understand the physics of those modalities. We said CT, same thing, CT and MRI, shortened schooling, pretty much at your discretion, and cross-training, definitely. Now, nuclear medicine, where we were, that absolutely requires more schooling. If you are a technologist and you go on for nuclear medicine, there is typically a shortened 1-year version where you can become a tech, and then you go for another year and you can become a nuclear medicine technologist. Now, nuclear medicine technologists require a lot of physics, a lot of chemistry as well, understanding the radiopharmaceuticals, which are of different chemicals and how they react to each other. So really strong in chemistry and physics for nuclear medicine, and about another year of schooling. They use nuclear energy of the atom, remember a radioactive atom, to create the medical images. The energy is in the form of gamma radiation. It uses radioactive isotopes, or those are the radiopharmaceuticals, to create the gamma radiation. So what they give the patient is radioactive. So in this example, the patient is giving off radiation. The gamma camera is simply detecting the radiation and recording it. But in these situations, the patient is radioactive, not the equipment. With us, the equipment gives off the radiation, not the patient. All right, so radiopharmaceuticals are given to patients to assess physiological function. So NucMed tends to look at the physiology, the function of the organs, more so than the anatomy. All right, and different exams depending on how long the patient is radioactive, because they typically wait for the half-life of the radiopharmaceutical. So it is possible that a NucMed patient is told not to be around any immunosuppressed or compromised patients, typically not allowed around young children or someone with cancer, people that have a suppressed immune system, typically for a period of hours. They would let the patient know, don't go home where your grandchildren are. Don't go around your husband who is undergoing chemotherapy. They just have to avoid them because they are radioactive, meaning that those tracers, those radiopharmaceuticals, are emitting radiation. So the patient is kind of radioactive at that point. If you go on for schooling and pass the registry in nuclear medicine, you would end up with the initial N behind your name. Now, another interesting thing is that you don't have to become a technologist in order to be a nuclear medicine tech. You can just go to school for nuclear medicine, and if you do that, then your initials would be totally different behind your name. If you go just for nuclear medicine, you would be a CNMT, which means you are a certified nuclear medicine technologist. And that means that you're not an X-ray tech first. You simply went to school for nuke med, so you're a CNMT, which is perfectly fine. It's just sometimes people that are technologists, they cross-train over there, they really enjoy it, and then they go on for the schooling. So if that's the case, then you would be an RT, and then the N behind your name in parentheses, also with the R as well. So you never drop initials, you add to it. And typically when you add to it, your newest initials come first, and then it goes out. So the R, if you had the R, that would be the last initial, and then whatever you got would go in front of that. Cardiovascular interventional technology, or CVIT. Now this person would ideally love to work in the cath lab. Again, you do have to take a registry in this in order to be competent to work in there. But most of the time when you cross-train like CT, MRI, cardiovascular interventional, they'll usually bring you in to cross-train, and they'll give you a time frame how long you have to pass the registry. Could be a year, could be 2 years, totally dependent on how bad they need you. but usually there is a time factor associated with it, because in order for them to be reimbursed for any procedures, it typically has to be a qualified practitioner, meaning that that person has passed the registry. So a cardiovascular interventional technologist uses x-rays to look at human blood vessels and the heart anatomy, so cardiac catheterizations, arteriography, things like that. So they use a catheter and they inject x-ray contrast into the patient in order to visualize the anatomy, because anytime you have a hollow organ or a hollow vessel, unless you put something that will show on a radiograph, like blood does not show on a radiograph typically, unless there's a large amount pooling somewhere. But if you wanted to look, think about when they want to look at the stomach or the esophagus or the intestines, they typically make the patient drink something called contrast, which will allow it to show on our radiographs. And these procedures for cardiovascular interventional are all done in a sterile environment. Typically, they're done in what they call the cardiac cath lab. You can see in this slide, they are all in sterile attire. The patient is covered with a sterile gown, and then what they're putting in is sterile equipment, and then all their images show up on multiple monitors so that they can look as they're going through. And typically the patient is awake for these procedures, but that's what they're doing. Everything would be sterile, especially if you're inside the heart and the blood vessels. Radiation therapy. This is another one like nuclear medicine where you would actually have to go to a separate school for this. Radiation therapy, if you are a technologist already, there are programs that are an additional year in length. But just like nuclear medicine, you do not have to become a technologist first. You could absolutely go to school just for radiation therapy. A radiation therapist uses high energy ionizing radiation, typically to treat malignant tumors. It's not always cancer, but I would say probably 98% of the time it is treating a malignant or a cancerous tumor. They tend to work with other oncology team members. They usually work with oncologist, which is the doctor that specializes in cancer treatment. They can work with a dosimetrist who figures out the dose that the patient needs. They'll work with a radiation physicist. Typically, minimally, an oncology team for a patient, there's about 5 people on that team. All right, and what they try and do is either cure the patient or improve their quality of life while they have this disease. So radiation therapy, that person, a radiation therapist administers radiation treatments to patients according to the prescription and instruction of the radiation oncologist. All right, and again, typically a 1-year program once you've become a tech. If that's the case and you go on, then you would have an initial of a T for therapist behind your name. If you don't go to school for to be a technologist and you just go to school to be a radiation therapist, then you would end up with the initials RT behind your name, which could be somewhat confusing, but in that instance, it would stand for a radiation therapist. If you're an RT, if you're a technologist that went on for another year, then your initials would be RT, which means registered technologist. Then you would have a T in parentheses for therapy, and then you would have R in parentheses for radiology. Okay, kind of confusing, but all of these that we've talked about require you having a certain amount of knowledge, whether you go to school for an additional time frame, whether you study on your own and get it, like with CT and MRI, but they do offer schooling. You do have to pass an additional registry in order to obtain the initials behind your name. Now we'll go back and talk about the history of radiology, and this is back on page 6. Those things that we just talked about started on page 6 and kind of went all the way over through page 10 when we looked at those. The history of radiologic technology is very, very interesting, and I am going to give you some additional facts that they don't mention in the book. X-rays were actually discovered. They were not invented. They were not created. They already existed. But Wilhelm Conrad Röntgen, and you can see the spelling in here. Röntgen is the R with the O with the little, I think that's called an umlaut above the O. I cannot do any justice to German pronunciation. It's a very throaty sound. It sounds like you're trying to hack up a hairball if you said this correctly, but the Americanized way to say that is Rankin, and typically you can see it spelled, the American version would be Roentgen, Rankin, and that is acceptable spelling as well as spelled like this. So they were discovered by Wilhelm Conrad Röntgen on Friday, November 8th, 1895. Very important day for us. He discovered them quite by accident in his lab at the University of Würzburg. That is Germany. He was in his lab working on experiments, and he noticed that when he darkened his room to get ready for the experiments for the following day, when he energized, what he was working with was called a cathode tube. And when he energized the cathode tube, he noticed a faint green glow over in the corner of his workspace. Now, there's different versions of this. I've heard that what he had was a screen that was coated with barium platinocyanide. So it was coated with this substance that actually glowed in response to X-ray exposure. Now, he didn't know that at the time. Nobody knew that. But I've heard accounts that this screen was in the corner of the room. I've heard that it was in a desk drawer that was open by his desk. But regardless of where it was, this screen was coated with platinocyanide, and it gave off light, or it fluoresced when it was exposed by radiation. So when he energized this Crookes tube that he was working with, when he energized that, he noticed it glowed, and when he stopped energizing the tube, it stopped glowing. Well, that caught his attention. He stopped what he was working on, and he literally spent the next 7 weeks fully immersed in trying to figure out what exactly made that screen glow. Okay, so 7 weeks he worked on this. So November 8th, 1895 is the first day, we think, that he saw this. And he ended up publishing a paper on December 28th of that same year, 1895, listing all the things that he figured out about these X-rays. Now, the interesting thing is, in his initial paper, he came up with 12 properties, 12 original properties in this paper. His paper was titled On a New Kind of Rays, and again, it was submitted on December 28, 1895 to the Würzburg Physico-Medical Society. So in this paper, he identified 12 properties of X-rays. And he was so thorough in his investigation that to this day, in 2020, no one has disproven any of his original 12 properties, nor have they added anything to those original 12 properties. So he was so thorough that he literally discovered everything there is to know about X-rays in his initial 6 or 7 week investigation, which that is crazy to me that he was that thorough. But he literally spent all his hours in the lab. He is married. His wife, her name is Anna Burke Ludwig, and she actually went by Bertha, even though her first name was Anna. He married her. There's accounts that she was extremely annoyed because he was literally eating and sleeping in his lab. Now, he was the chair of the physics department at the University of Würzburg, so they actually lived at the university. They lived in the bottom section of the university as their housing, and his lab was in the top of the university. So it wasn't like she couldn't get to him. He literally was right there. But he was so immersed in his investigative procedure that he didn't go home. I mean, he literally ate and slept. She brought him meals to the lab. He slept in the lab, and he spent every moment he could working on that because he was just so probably excited for the investigative process, and he just spent all his energy working on that. They did have one adopted daughter. It was actually his wife's niece. They adopted her. They had no biological children, which might be because they were actually third cousins. Anna Bertha Ludwig and Wilhelm Conrad Rankin were third cousins, and they had an adopted daughter, no biological children. So he published this paper on December 28th, 1895. It went rapidly around the world like wildfire. We were actually using, we were imaging in this same manner by the January of the next year. So January of 1896, people were making their own, x-ray tubes and trying to image things. Now, this picture we have right here, this is Bertha's left hand. This is her wedding ring right here. This is given credit as the first x-ray because he submitted this along with his report to that Physico-Medical Society on December 28th. He submitted this picture along with his report, and this is actually Anna Bertha's left hand. He took an image of her. This is her wedding ring. Where it should be, I know it looks a little weird, but this is her left fourth digit or her ring finger, and that is actually where the ring sits. This would be her knuckle right here, or it's called a metacarpophalangeal joint technically, but this is the knuckle. You can see this is where all the knuckles would be, and this is the bones that are in the palm of our hand called your metacarpals. So this is Anna Bertha's left hand, and that is given credit as the first x-ray because that's what he submitted when he submitted his paper. Again, 12 original properties. We can talk about those when we discuss our live, but nobody has taken away from those, nor have they added to it. So pretty impressive that he was that thorough in his investigation. At the time, he was using what's called a Crookes tube. That Crookes tube that he was working with was a partially evacuated, now we would say a partially evacuated x-ray tube, but they've partially evacuated, meaning it still had some air in it. Now we use a fully evacuated tube, and it is called a Coolidge tube, and they came out with those in 1913, so about 18 years after x-rays were discovered. For those first 18 years, they were using the Crookes tube, and the Crookes tube just had partial evacuation, meaning it had some air in it, which meant that x-ray times were much longer. We'll talk about that. X-rays actually took anywhere from 20 minutes up to 2 hours to take an image. This hand x-ray that he submitted, it took 15 minutes to capture this image of his wife's hand, meaning she had to sit there for 15 minutes with her hand still. And I know you probably think, oh, this isn't a very good image, but honestly, compared to modern x-rays, this is absolutely not a bad image considering it was taken in 1895. So again, Rankin was extremely intelligent, very thorough in his investigation, and as a reward for that, in 1901, he actually received the first Nobel Prize in Physics. That is not to be confused with the Nobel Peace Prize. That is something totally different. The Nobel Peace Prize is given to someone that brings about peace or helps to bring about peace in a situation. So this is different. This is the first Nobel Prize in Physics, and it was awarded to Rankin in 1901 based on his investigative efforts and everything he had worked on. So 1901, first Nobel Prize in Physics. This is not in your book, but in 1904, another significant date, so 1895, x-rays were discovered, 1901, first Nobel Prize in Physics, and then in 1904, this was when they gave credit to the first radiation fatality, meaning that this gentleman, Clarence Dally, his death was completely and wholly attributed to radiation exposure. Now, Dally was Thomas Edison's assistant, so it's kind of crazy to think that Thomas Edison and Wilhelm Conrad Rankine were contemporaries, that they lived at the same time. That's just odd to me to think about. But Dally was Edison's assistant and spent a lot of time, they both did, working with x-rays once they were discovered. They actually worked on what was called a fluoroscope, which is like our modern fluoroscopy, meaning it was live imaging of the anatomy and the parts. So this live imaging that was done, Clarence Dally a lot of times was holding the fluoroscope, which means he got a lot of radiation exposure. We didn't realize how bad that radiation exposure was. It took about 3 years for the first effects to actually be shown. So that would have been 1898. They noticed that there was reddening of the skin, there was unhealing sores that came about. Radiologists and technologists started wearing black gloves over their hands to cover these sores. But nobody, it's kind of like when you go out in the sun. If you go in the sun, some people turn red right away, but a lot of people, they'll be out in the sun and it won't show up until hours later where they actually turn red because of the sunburn. And now that actually is a form of radiation. It's cosmic radiation that we're exposed to. But the same kind of thing can happen with the radiation they were using back then, which was unfiltered. So Dally would end up with these unhealing sores his arms and hands and legs. And when he died, he ended up, the only way they knew how to cure those unhealing sores was to amputate. So when Clarence Dally died in 1904, he literally had no arms. They were starting to amputate his legs. He was miserable. He couldn't sit, he couldn't stand, he couldn't lie down. It was an agonizing, traumatizing death. And Edison witnessed this because not only was he his assistant, he was likely his friend, but Edison was so traumatized by his death that Edison actually refused an x-ray. He had abdominal issues and they wanted to x-ray his abdomen after Dally had died, and Edison refused. And because of that, he ended up dying of the complications. But had he had that x-ray, it likely could have saved or prolonged his life. But he was so traumatized after seeing his friend suffer like that that he refused the x-ray. And again, this is not in your book. So 1895, x-rays were discovered. 1898, first radiation effects were noted. 1901, first Nobel Prize in Physics. 1904, first radiation fatality, which was Clarence Dally. Now, what I'm not saying is there probably were other people that could have died from radiation poisoning like Dally, but 1904, this was the first documented case. This was the first case that they could absolutely say the reason he died was because he was overdosed by radiation because of what his work involved. All right, now, as a career, radiologic science as a career, we have a huge variety of career paths. You've already seen CT, MRI, cardiovascular, nuclear medicine, radiation therapy, huge career paths that we can take. It often begins with a general radiography background, which is what you're in school for now. The specialty areas do require some additional education and certification. I would say they all require certification. As far as the education, it could be minimal, where it's like a weekend course that you go through, or it could be a year or more of schooling is required. And the career opportunities are limitless, and the demand and desire for professional success is huge. A lot of times students will graduate and say, oh, they're not going to go on for anything else, but then you start working somewhere and they say to you, hey, we'll pay for you to go to school to get your CT registry, or we'll pay for you to get MRI certified, or we'll pay, I mean, if your job is willing to put you through school and pay for you to get that certification and you get those initials behind your name, you know, sometimes you're required to work there for a certain period of time, but a lot of times they just really like you and they want you to further your education so they could utilize you more. So that's a huge win-win. Some of the different career opportunities that we've mentioned. You could go into, obviously when you graduate, you will be in radiography. You could go into CT scanning, medical sonography, radiation therapy, MRI scanning, mammography. We didn't mention that. You could image the breast. Both males and females can go into mammography. I'd say it's a little bit harder for males, probably to work in that field, but it is absolutely a possibility. I know some male mammographers. DEXA scanning, that you can find that on page 9 under bone densitometry. Bone densitometry, they use that to diagnose osteoporosis, which is typically found in menopausal women, but it can occur in men as well. And osteoporosis is where there's a loss of calcium from the bone. It demineralizes, so the bone becomes thin and weak and very prone to fractures. So they do what's called a DEXA scan, and DEXA stands for dual energy X-ray absorptometry. And again, this is on page 9, but this is the exam that they do. They do a DEXA scan, and the person that does the DEXA scan is likely a radiographer, but they could go on and get their registry in bone densitometry, so they would get the initials BD behind their name. You could become a radiologist assistant. Now, a radiologist assistant, that is actually found on page 8. A radiologist assistant or a registered radiologist assistant, typically they use the initials RRA. That requires additional schooling because a radiologist assistant or an RA is very similar to a PA in the medical field, which is a physician's assistant, which means they have advanced level training. So a radiologist assistant has more education than us as technologists, but not as much as a radiologist. They're kind of in between. They're higher than us, but lower than a radiologist. But they have more responsibilities closer to the radiologist. They assist the radiologist side by side. They do a lot of the radiologist's work. They help them out. So an RA is very similar to a PA in the medical field. It requires additional schooling. It takes about 5 years to become an RA because you have to be a technologist for at least 5 years before you can consider it. And then typically there is a 2-year educational process that you have to go through. But that is something that you are able to become. And then your initials, if you pass that registry, you would be an RRA, which would mean you're a registered radiologist assistant. You could also go into nuclear medicine like we talked about and use the gamma radiation, the radiopharmaceuticals to detect, to look at the physiology of the patient. We also mentioned cardiovascular interventional where you would work in the cath lab. You could go into administration if you chose to. When they talk about administration, that is actually on page 11. You could go into the administrative aspect of the field. You could go into education. You know, I can tell you that when I graduated, they mentioned going into education, and I never in a million years dreamed I would do that. But here I am 16 years later. I actually do enjoy it very much. I love patients. I love this field, but I do enjoy seeing students learning about it. I love to see the light bulb go off when they understand concepts. It's very rewarding to see you all working out in the field and loving this profession as much as I do. And I can honestly tell you, 30 years later, I do still absolutely love this profession. Love it with everything in me. You could go into research. You know, different opportunities arise, not only all of those that we talked about, but education is an option, research is an option, administration is an option. You could go into commercial sales. You go into commercial applications like teaching people how to use specific programs that are created. You could go into servicing equipment. So many different opportunities that we have. When we do talk about education, I just want to point out that there's different roles that you could have in that. I am what's considered a didactic faculty member, meaning my primary role is in the classroom and lab setting. You could be a clinical coordinator, which that person is responsible for you all out on clinical sites. They're like the liaison between the school and the clinical site. You could be a program director, which you have teaching responsibilities, and you have the overall administrative responsibility for the entire program. That is what Dr. White is. She is our program director. Mrs. Stevenson is our clinical coordinator. Didactic faculty is myself and Mrs. Ray. We teach the bulk of the classes in the program. And then there's also what's called a CI, or a clinical instructor. They are actually the techs that you work with out in the field. They are on your clinical sites, and they teach you guys on a one-on-one basis in the clinical setting. The interesting thing about a clinical instructor, they do not get paid for that. It is just something that most likely they love the field. They love imparting knowledge to the next generation of technologists, and they kind of take you guys under their wings when you're out on clinical sites, and they're responsible for help guide you and teaching you out in the field, and they work with you more one-on-one. So those are some different opportunities in education. Administration, you could be the lead tech, you could be a radiology administrator, radiology manager, you could move up the ladder, which with administration, it requires more schooling because you typically need a bachelor's or a master's degree. All kinds of opportunities for you. As far as radiology, there are so many different names that we could be referred to. They talk about radiology, x-ray, medical imaging, diagnostic services, imaging services, or just plain imaging. All 6 of these are interchangeable. We can absolutely, you'll see different facilities use, go to the radiology department, go to the x-ray department, go to the imaging services department, go to imaging, go to medical imaging. They can call it anything they want, but the bottom line is that it's predominantly a diagnostic service, like we're doing something to diagnose the patient, and we focus on imaging or taking pictures of patients to diagnose their medical condition. We take those images to either confirm or deny the presence or the absence of a disease process, of a fracture, of some kind of medical ailment that is affecting the patient. It is our job to image that particular anatomy to confirm or deny that diagnosis. So all of these names are things that we can be, that our department typically is referred to, and us as technologists understand that. Now, are we the only members in the healthcare team? Absolutely not. The other members of the healthcare team are physicians, we have medical doctors, and we have doctors of osteopathy. Medical doctors and DOs tend to go through the same training. Honestly, DOs have more training than an MD because they typically deal more in holistic medicine. DOs tend to do things by manipulations, like a chiropractor is a DO. So they manipulate the body to improve it. They'll provide exercise regimens, diet regimens, things to holistically heal the body, versus an MD tends to focus more on prescriptions, imaging, prescriptions, things like that. There's nothing wrong with either. It typically is dependent on the patient. Patients tend to respond differently based on what they prefer. We have nurses as well in the healthcare team, allied health personnel, meaning lab services, x-ray services, all the allied health departments, physical therapy, occupational therapy. And then we have supporting members and non-clinical members of the healthcare team as well. It says that most health careers are referred to as allied health, and hospitals basically are communities within a community. When we talk about, I just do want to point out real quick, when we talk about the healthcare team, and I asked if we were the only members, we are the radiologic technologists that work in this department, but we are called technologists, not technicians. And if you look on page 11, they spend a few paragraphs talking about that technologist and technician are used interchangeably, but that is not correct to do that. Typically, a technologist has more advanced education. We tend to use critical thinking and problem solving. A technician, there's nothing wrong with a technician, but a technician typically doesn't have as much education, and they tend to approach the process the same way every time. Like, I'll give you an example. A technician, I think of someone like my son, works on cars. Okay, you could think of him as an automotive technician, meaning that if you bring your vehicle in there, my vehicle, if I bring in my 2006 Chevy Impala, there's a manual that goes with that. So every time my car goes in, that technician is going to look at that manual and fix my car based on what that manual says. Every time any 2006 Impala that goes in there, they're going to treat it the same exact way, because that's that 2006 Impala, and that's how you treat it. And that is a technician. Did he go to school? Absolutely. A technologist, though, what do we work on? We work on patients, and that patient is the biggest variable, meaning that patient presents, every single patient you interact with has a different issue or a different problem. Even if they have the same problem, it's a different patient, different body habits, different issues, different things that make them tick. So we are forced to critically think and problem solve our way through. There is not a manual that tells us how to deal with every kind of patient every single time. We have to use our education and our skills to diagnose that patient, to how do we treat that patient, how do we get an image on that patient that is not able to stand. How do we get an image on that patient that's a quadriplegic confined to a wheelchair? How do we get an image on that 2-year-old that will not hold still no matter what we do? We are forced to critically think and problem solve, and typically technologists have more education than a technician. So you will find that one of my pet peeves is when people refer to us as technicians. It drives me absolutely insane. But from me to you, just know that a technologist typically uses critical thinking and problem solving, and we typically have more education than a technician does. Is there anything wrong with a technician? Absolutely not. All right. In conclusion, X-rays were discovered by Wilhelm Conrad Röntgen on Friday, November 8, 1895, at the University of Würzburg in Germany. Medical imaging is made up of many diagnostic areas involving energy, and particularly radiant energy, meaning radiation, which has the ability to ionize atoms. It is not completely safe. It does have the ability to harm the patient, and we always have to adhere to the ALARA principle, which stands for as low as reasonably achievable. Radiologic science professionals perform an essential member. We are essential members of the healthcare team. During the COVID-19 pandemic, radiology was absolutely considered essential as far as working, maintaining work in the field. Pretty much every member of healthcare was involved, unless they worked strictly in outpatient services. Those services were suspended, but everybody else typically is considered an essential employee. Career opportunities are limitless in our field. You just have to want it, and you have to seek opportunity in that, whether it means additional education, cross-training in your particular hospital where you work. If you want to do it, I absolutely guarantee you there is something out there. You just have to go out on clinicals. But one of the points of clinicals is that you go out and decide and figure out what it is you love to do, what patients you like to work with, what interests you, because your job, you spend more time at your job than you do at home. So you absolutely should love what you do. And if you don't, I would tell you you would have to get out, because you spend way too much time to not be happy while you're at work. Most of the time, if you love what you do, then you don't even think of it really as work. You go to work, you enjoy your job, you go home, you enjoy your family. But if you don't love what you do, then you should change what you're doing. All right, we will meet up and talk. If you have any questions or comments or concerns, I do hope you wrote them on those slides, and I hope you bring them to the table when we meet up again, and we will be able to discuss that. Thank you very much.